Good morning. It is Tuesday, so I usually do Monday, Wednesday, and Friday, and was unable to do class yesterday because I was substitute teaching in high school algebra. So I found some pretty good little memes on algebra. You want to check them out? Okay, so this class, uh, I got the idea for this class from Tammy Crabtree, um, who is a nutritional health coach and physical fitness guru in Oklahoma. Um, and she's a co-health coach with me, and she posted about cholesterol, specifically ratios. And I thought, well, so we'll do that at next class. So we're going to talk about cholesterol, do a little review on cholesterol. Good morning, Eileen. We'll do a little review of cholesterol, actually a fairly decent review, and then we'll talk about particle size and what that means, and why you should actually be asking your doctor to not just do a fasting lipid panel. Because Tammy's main gist and point was that total cholesterol, that number doesn't really mean a whole lot. You need to know what makes up that number. And we've talked about the levels being too low as you get older. That's a whole other class that we did in the past. So let's just review cholesterol. What is cholesterol? It's just basically a fancy organic molecule, but it has an interesting distinction. So it's part of your cell wall, every cell wall. It makes your cell wall fluid, and it protects you from things getting into your cells that shouldn't be there. So the interesting distinction of cholesterol is we eat it, we make it, we store it, and we excrete it, and that's all in different amounts. Okay, so the pool of cholesterol in our body is essential for life. So if you do not have cholesterol, you would not be alive. So all you hear about is, yeah, cholesterol's bad, etc. Don't eat it, blah blah blah. Well, without cholesterol, you don't live. Okay, so the whole point of cholesterol is it's pretty important. And for 40 some years, since 1978, and a little bit of a change in 2015 from the USDA on eating, cholesterol has been kind of the bad boy of our diet. So there's two forms of cholesterol. There's unesterified or free cholesterol, and then there's esterified cholesterol. And the form of that cholesterol kind of determines if we can absorb it or not, or store it or not. And there's some other things that esterified and unesterified cholesterol does as well, but that's the basics. Can we absorb it? Can we store it? So much of the cholesterol that we eat is esterified cholesterol. So it's not absorbed, it's excreted by our gut, and it leaves the body in our stool. And the reason is that cholesterol not only has to be de-esterified in order to be absorbed, but it competes for absorption with the unesterified cholesterol that's supplied through the biliary system in the liver. So reabsorption of the cholesterol that we synthesize in our body. Okay, so the body's production of cholesterol is called endogenous produced cholesterol. That's the dominant source of cholesterol in our body, at least 80%. Okay, so most of the cholesterol in your body was made by your body. You didn't eat it. Okay, so regulating cholesterol is complex, lots of layers of control. We talk about this. Actually, we're talking about that specific topic in my human physiology class at 2 o'clock today. We went back to virtual teaching, so I'm teaching on Zoom through State Fair. We're doing the digestive system. We're going to talk about absorption and production of cholesterol. Okay, so the synthesis of cholesterol, very complex, it's very regulated, and so synthesis and absorption are interrelated. So eating cholesterol, very little impact on the cholesterol levels in your body. The vast majority is made by your body because you need it. Okay, so that's just a fact. most of the cholesterol in your body made. And somebody that tells you that that's not true probably doesn't know that much about cholesterol biosynthesis and the significant importance of cholesterol. The Canadian guidelines for eating removed limitation of dietary cholesterol many years ago, and so the rest of the world really needs to catch up, especially the United States. So there was some toned down language from the federal government food guidelines, in that I think they said something like the ingestion of cholesterol is neither bad nor good, basically. It's more eloquently stated than that. Okay, and then remember, cholesterol is a fat, so it's not soluble in plasma. So plasma is 92% water. Okay, so they're hydrophobic molecules. So triglycerides and cholesterol, so the fat you eat is triglycerides. And in order to be carried anywhere in the body, so let's say from your liver to a target organ and back, they need to be transported by lipoproteins. So those are the taxis I'm talking about. LDL cholesterol or LDL carries cholesterol from the liver, where it's synthesized, to target organs. We talk about cholesterol use in gonadal hormone production, because gonads do not produce their own cholesterol, but cholesterol is the basis of steroid hormones, and the sex hormones are steroids, so they have to come from cholesterol. So basically, the taxis are lipoproteins. So the LDL leaves the liver, and they mature, where they shed most of their triglyceride or fat, what they're carrying, in the form of free fatty acid. And so doing that makes them smaller, and they're richer in cholesterol. Okay, and then special proteins called apoproteins play a role in removing lipoproteins around the body, moving lipoproteins around the body, and help facilitate interactions with other cells. So the most important of these are the apolipoprotein B class, and they reside on VLDL, very low density lipoprotein, intermediate density lipoprotein, and low density lipoprotein particles. And then there's apolipoprotein A. That class is for the most part on high density or HDL particles, so they're wrapped around the particle. So you can transport cholesterol both ways. So from the liver and small intestine toward the periphery, and then back to the liver and the small intestine or the gut, which has its own little brain, the gut brain. We'll talk about that in physiology this afternoon. So the major function of the apolipoprotein B containing particles is to transport triglycerides to muscles and phospholipids to all cells. Okay, and then those cellular cholesterols are trafficked back to the liver. And the apolipoprotein A containing particles transport cholesterol to the steroidogenic tissues and the adipocytes, so fat cells. Okay, and that's for storing cholesterol ester, and then ultimately back to the liver, the gut, or steroidogenic tissue. Okay, so tissue that makes steroids, like the adrenal gland and the gonads. So all lipoproteins are part of the human lipid transport system, and they work in harmony to transport cholesterol and triglycerides back and forth. So the lipoproteins are constantly changing the surface lipids and the core amount of cholesterol that they're carrying, because cholesterol is necessary for life. Okay, so measurement of cholesterol over the past 70 years has changed based on technological advances. So most people in the U.S. get a standard lipid profile. They usually want it fasting. There's a big, huge Norwegian study that showed that fasting lipid panels really aren't that much different than the ones that are not fasting. So theoretically, they want you fasting for 8 hours. So most people don't eat anything after midnight. And so you're directly measuring total cholesterol, triglyceride, and HDL cholesterol, high density. And remember, it's a taxi, it's a lipoprotein, high density lipoprotein. Okay? most of the time, LDL, low density lipoprotein, it can be measured, but more often it's estimated, it's calculated. Okay, so there are advanced techniques in order to directly measure low density lipoprotein. None of those are standardized. And as well as the cholesterol content of the other lipoproteins, the very low density lipoproteins and the intermediate density lipoproteins. So the most frequently used and the recommended guidelines are the tests that can count the number of LDL particles is either the apolipoprotein B or the LDL particle by nuclear magnetic resonance, and that's part of an NMR lipoprofile. I alluded in Tammy's post to the VAP cholesterol, which was developed by a company and is actually used to be done by Quest and LabCorp, and they no longer offer that. The little lab test that I put up as the intro to this class was from Health Diagnostic Labs, which then was taken over by True Health Diagnostics, and now they are out of business. So you can't get really a VAP cholesterol without ordering each specific test. Okay. Okay. So what does it mean? So the value of size of particles is important in predicting insulin resistance before changes are noted in glucose and fasting insulin levels. So we've talked about the fact that heart disease really is sugar-based, insulin resistance-based, type 2 diabetes-based. And so the progression from a normal artery to a clogged or an atherosclerotic one follows a clear path. So an ApoB containing particle gets past the endothelial cell layer, which is only one cell layer, and it gets under that layer where the particle and its cholesterol content gets retained. You get an immunologic response and an inflammatory response that fixes the ApoB containing particles in place and then makes more space for more of them. So it's inflammation, immune system response. Okay, so it's not the cholesterol, it's the immune system response and the inflammatory response. After inflammation has started forming cracks in the walls of the arteries so that ApoB containing particles can get underneath that single cell layer. So what drives the process is the penetration through that cell layer, and then the fact that it retains those particles and cholesterol within the endothelial space underneath the one cell layer. So the most common ApoB containing lipoprotein is LDL. Okay, there are also others that play a role. So like lipoprotein little a, which is a measurement that can be done. You have to order it specific. And anybody that has a strong family history of heart disease should have a lipoprotein little a level run. And so this is very important in people that become insulin resistant. So people that like to eat lots of carbs become insulin resistant. So if you want to stop atherosclerotic progression, you must lower your low density lipoprotein particle number. So the numbers, the size is important as well. So at first you would think that smaller particles had a greater risk for sticking in arteries than patients with larger LDL particles. But it turns out that that's not true. So the larger LDL particles are actually safer. Okay, it's a variant called LDL particle size A and B, and the B ones are are smaller, right? So a particle's a particle's a particle. So, and actually I said that backwards. You would think that larger, it's true that smaller LDL particles cause trouble, and you would think larger ones would, but they don't. They typically sail right through. Okay. So there are two markers in labs that have a correlative effect with a given outcome. So there's concordance, where they predict basically the same outcome, but when two tests do not correlate with each other, they're called discordant. Okay. So the best predictor of adverse cardiac events is really LDL particle size or apolipoprotein B levels, because that LDL low density lipoprotein is covered by apolipoprotein B. Okay, so that's been documented repeatedly. Lots of cardiovascular risk studies talk about LDL particle size and ApoB. Okay, so LDL volume, the number, the volume, the amount, it is only a good predictor of adverse heart events when it's concordant with the LDL-P particle size. So in other words, like we talked about eating higher fat diets, I think 2 weeks ago or last week, you can have a high LDL count or volume if you have the good kind, the larger LDL particles. So a higher number of large LDL particles, the LDL level itself, the volume, really doesn't make a whole lot of difference. If you have an elevated LDL and you're running around with type B, smaller LDL particles, and a lot of them, that's more predictive. It's concordant. So there's no way to determine if you have discordance or concordance between your LDL cholesterol volume and your LDL particle number and size without measuring both of those. So if you just order a fasting lipid panel, you're not going to get that. You have to ask for it. You have to have a physician write the order. Okay, and then the discordance between LDL volume and LDL particles is even higher in people who have metabolic syndrome, and they're becoming insulin resistant and eventually can become type 2 diabetics. Okay, so there's more to the story is the whole point. All right, so it's difficult to justify just measuring a lipid panel for assessing risk of heart disease, especially in people who have metabolic syndrome, type 2 diabetes. It just doesn't correlate, so it's discordant. So, so you have to kind of look at changes in cardiovascular events or direct markers of atherosclerosis while holding the particle size of LDL constant and then holding the LDL size itself constant, so the particle number and the LDL size. Okay, so the only thing that really matters is the number of LDL particles and whether or not they're large or small, and there's a mixed, which is an A/B variety as well. Okay, so HDL levels and HDL particle number are not measuring the same thing, just like LDL levels and LDL particle numbers are not measuring the same things at all. So secondary to total HDL particles, it seems that smaller HDL particles are actually more protected than the larger ones. So it's the reverse with HDL. So as HDL levels, volume, rise on a fasting lipid panel, most of the time it's due to a disproportionate rise in HDL size itself. So either larger or smaller. Okay. So in trials, clinical trials designed to prove that a drug raised HDL would provide a reduction in cardiovascular events. So that's the thinking. That's the good one. That's good cholesterol, HDL. There was no benefit. So you get no benefit from raising HDL per se, the level, the volume. So the estrogen studies, fibrate, like fenofibrate studies, niacin studies, etc., is looking specifically at HDL volume, but it has nothing to say about HDL particles, number of particles. So HDL is important. More HDL particles are better than fewer HDL particles, but raising HDL levels with a drug, which technically you sort of can't do, so making that even more complex is that HDL functionality is likely as important or even more important than HDL particles, but there's no way to measure that. Okay. So the question is not how can you prevent stuff or eliminate the risk of cardiovascular disease, or specifically how can you delay it. So there's a difference. Okay. Um, so age is related to that. It's a risk factor for cardiovascular disease, just like your blood pressure goes up with age. We talk about age at the end of each chapter in anatomy and physiology. So age actually provides a better cause model for atherosclerosis than the typical age-driven models, and why age is an important risk factor. Okay. So what we're going to do, now that you know that there's a difference in particle sizes, is so our next class, and I've got to run off and teach anatomy pretty quick. Hey, another Eileen. Hi, Eileen. So I'm going to go teach at the college virtually, but since Tammy brought up the ratios, so total cholesterol to HDL, total cholesterol to LDL ratios, and probably LDL to triglycerides is the most important one, and then the biggie really is apolipoprotein B, small LDL particle size, and elevated lipoprotein little l. Those are the three biggie nasty ones. So we'll talk about ratios in class either tomorrow or Thursday. So I do have it cleared up for Thursday at 9:30, so I can go teach at 10:15. And then if I get called in on high school, I can't just break out and start teaching a class online at 9:30 in the middle of class at high school. So I will talk to you either tomorrow or Thursday morning at 9:30, and we'll talk about cholesterol ratios and why that's more important than total cholesterol levels. So you know that size and particle number now are more important than volume. The actual, and remember LDL a lot of times is estimated, so it's calculated. Okay? So have a great day. I gotta run off to the college, and I will talk to you either tomorrow or, what is this, Tuesday? So tomorrow or Thursday at 9:30. Thanks for staying in. See ya. Bye.